Hello and welcome to the Rocky Mountain Short Takes on Suicide Prevention podcast. I'm Melissa McCarg, and today I'm really pleased to be joined by Scott Snow, the Director of Crisis Services Division at the Denver Police Department, and Chris Richardson, who's the Program Manager of the Mental Health Center of Denver. Both are part of the city's Crisis Intervention and Response Unit, which is a program that got off the ground in April of 2016. And today they'll be sharing information about the CIRU and how it improves Denver's response to mental health needs. So welcome very much, Scott and Chris. We're glad you joined us today.
Thank you. We're glad.
Thanks for having us.
Well, let's just get started. I'm going to jump in with the first question. So I'm wondering if each of you could take a few minutes and describe your role in the CIRU and your connection to mental health crisis response in Denver in general.
Chris, would you like to start?
Sure. So, Chris Richardson, a licensed clinical social worker with the Mental Health Center of Denver. I am the program manager of the Crisis Intervention and Response Unit. We've been doing this since about April. The connection to the mental health crisis system, the Mental Health Center of Denver is the largest mental health outpatient treatment provider in Denver, and we engage with individuals seeking treatment from, a large range from low-level anxiety, depression, trauma work to the higher symptomatic schizophrenia, bipolar, higher need case management levels. Been working with them for about 10 years. Really enjoy the work that the Mental Health Center of Denver really does and engages in the community. And when the opportunity arose for kind of this crisis division and specifically going out into the community with first responders, the police department jumped at the opportunity to play a role in that.
That's terrific. How about you, Scott?
Sure. But just a brief backstory. The Denver Police Department began crisis intervention training in about 2002. When Chief White came in 2012, one of many things that he asked that we take a look at, consider revision, was our CIT curriculum. So we looked around the country, starting with Memphis Police Department, where crisis intervention training originated in law enforcement in the United States. Looked at a number of different agencies and developed what it kind of is an amalgam of numerous training approaches and curriculum to the Denver CIT model. So that was kind of the genesis of the Denver Police Department's initial involvement, at the same time working with Denver's Office of Behavioral Health Strategies and Crime Prevention Control Commission, who was very focused on, then described as a co-responder model. They'd looked at Seattle and San Antonio and Johnson County, Kansas, a number of agencies that deployed clinicians, licensed clinicians with police officers. So we started integrating our CIT training and our interest in having clinicians at the same time working with the International Association of Chiefs of Police, recognizing that law enforcement agencies across the country were struggling with the same issues that the Denver Police Department were, and specifically trained law enforcement officers handling increased calls for service involving citizens with known or suspected behavioral, mental health, substance abuse issues. So it was kind of a perfect marriage of our timing with the Office of Behavioral Health Strategies, Crime Prevention Control Commission, some of the mayor's specific priorities with improving response to citizens within the city, county of Denver. So we contracted through Office of Behavioral Health Strategies and Mental Health Center of Denver to create now what is our Crisis Intervention Response Unit.
Wow, that's terrific. And if I'm correct, your role has been with the victim services, is that correct?
Historically,
yes.
Victim Services, our Victim Assistance Unit, is one of the units within the Crisis Services Division that I oversee. And so the Crisis Intervention Response Unit as another unit within that division. Because of our relationship, it's more of a liaison. It's within the Denver Police Department because the clinicians are working at the request of and with the population that interacts with the Denver Police Department. It's more of a partnership than it is a dedicated assigned unit, but it is a unit within the Crisis Services Division.
Gotcha. As I understand it, the CIRU plays other roles besides the co-responder unit. Could you tell us a little bit about those?
Sure. So based on some of the programs that we observed around the country, our initial thought was we're going to bring in clinicians, we're going to pair them with officers to ride in cars, and that would be kind of the exclusive partnership. One of the things I think Denver has done well and successfully is rather than law enforcement tends to create policies and procedures and protocols, and then put people in place to implement those. What we've done with this model is to be more experiential, to say we need good, trained clinical staff that know their jobs. They've been clinicians long before they ever came to the Denver Police Department. So we said, you go out and evaluate, tell us how we need to build this effectively. So we learned early on that sole pairing of officer and clinician, a significant amount of their time was spent writing, basically, not engaging. We have a solid idea of who the largest behavioral health consumers of public safety resources are. So rather than just putting a clinician in a car with an officer and wait for something to happen, that's still a part as a co-response, but proactively engaging people that we historically have had interactions with both through the Denver Police Department as well as MHCD or other mental health service providers.
So what would that entail? What would that look like? Are you going out proactively and seeking out individuals that you know may have these needs that are unaddressed?
It is a unique experience. When we decided that the ride-along time was kind of unused space, so we started to develop kind of a referral system where police that maybe weren't with a member of the CIRU team, that instead they were able to say, hey, we came across this individual in the community last night that presented with these kind of behaviors, or what we would consider like symptoms. And then they would give a referral that said, we really believe that this individual, or maybe this family, or maybe just, the surrounding family really could use support in getting this person some social support, connections in the community. And that's when we, in that moment, would be able to either contact the officer and say, hey, we'd like you to be part of this, or the officer, depending if they're in night shift, kind of allow us to partner up, and we would just go as a member of a clinical team to go engage someone in essentially just a discussion referencing, hey, we know that you had police contact yesterday. We'd love to be able to help you and see what kind of services we can provide, whether that is from a mental health, behavioral health kind of support, or it's just someone needs to talk to someone in that moment and get directed to, when you're in crisis, here are great places other than police contact that you can go to.
I think also, Melissa, if I could add to that, particularly topical relevance on suicide prevention, it's a small but critical part of what we've developed as well. Is any officer that responds to an apparent or known attempted suicide will create a report that's routed to us, and then we assign that to our clinical staff. So ideally, within 24 hours of that attempted suicide, the clinicians are attempting to make in-person contact and look at the issues to help kind of mitigate the future likelihood or probability that there'd be another suicide attempt.
That's really terrific, particularly since it's kind of responding to that very critical 24 to 72-hour period where a person might be at an even greater risk.
Absolutely.
Right. What I'm wondering is if, Chris, maybe you could kind of, or Scott, give an illustration of, I remember reading in a couple of the articles, and we will provide those links for our listeners, and one thing that really struck me is, Scott, when you said that in the past with this kind of response, it's kind of been lather, rinse, repeat. And I'm wondering if you could give an example of how the scenario might have gone in the past as how it might go now to kind of illustrate the difference between the two.
In complete support of the professionals that make up the Denver Police Department, as much CIT training or other outside training that they may have, they'd be the first to recognize they're not clinicians. They don't have a clinical background or even necessarily a therapeutic background that promotes additional options other than to take someone on an involuntary mental health hold, to communicate with them to where they agree to go on a voluntary mental health hold, to cite or jail. And those really are the four basic options for any law enforcement professional anywhere in the United States. So that's the lather, rinse, repeat. It's the contacting the same person engaged in similar behavior. The officer goes through their ability to assess and determine course of action, limited to those four. And we'll see you again in 3 days, and we'll do it all over. When they've taken them to the hospital, they're effectively observed, evaluated, released, and go right back to the same circumstances. So what we've seen in a relatively short period of time since April is, with the training, the education, the background, the resourcefulness of our clinicians, is those four options may still exist and may still be necessary. We look at looked at some of our numbers from April until about mid-December. Our clinicians had over 1,100 contacts with citizens.
Wow.
And fewer than 2% resulted in jail or citation.
That's amazing.
So that it completely changes the options, the cycle, the approach for people struggling with behavioral health issues.
Would you have similar numbers for before this program began?
We're challenged at this point the way our data is collected. The simplest way to explain is we collect a lot of data in a narrative format. So we would have to literally read through hundreds, if not thousands, of narrative reports to determine what the outcome from contact with the officer was. We're moving to a more efficient data process this year, so it's hard to compare prior, but we know anecdotally and directly that those options that I mentioned were the only for the most part, that officers ever had.
Right.
And that's the unique part about the collaboration between the Denver Police Department and kind of like the mental health, social work type field is there's definitely a, yes, no, data-specific collection that the Denver Police Department has access to and does do. And then you have a community organization that definitely is more, we want to know how the person's doing, want to know what they're doing in their life to expand. And being able to put a qualitative kind of numbers to that it's shown a little more difficulty, but it's something we're working on.
Wow, that sounds terrific. I'm kind of wondering if we could talk about some of the other, not just suicide prevention resources, but Denver has recently built different kind of crisis resources for individuals. And I'm wondering if maybe Chris could tell us a little bit about those and how the co-responder and the CIRU utilizes those resources.
Yeah, so Colorado's created new systems to be able to really have the greatest impact on individuals in the community that might be having that behavioral health crisis. The one that comes to mind immediately is the walk-in crisis centers. I think there's 6 within the kind of Denver County city area. That essentially is anyone that is in a perceived crisis, whatever they dictate that crisis is, are able to go there 24 hours a day, 7 days a week, and be able to meet with a trained clinical staff to problem solve, have someone just listen to them, be able to provide resources, and really be able to provide that immediate support to someone in order to help them manage, what they're going through and experiencing in that time. Individuals that kind of go outside the realm of they're just really having a rough time, maybe need a little more long-term stabilization. We have the crisis stabilization unit that can be accessed, that have staff on site 24 hours a day, that someone's able to possibly stay the night for multiple nights just to kind of have someone monitoring them to make sure that there's continuity of care and that they're, that they're safe and that they feel safe. So we access those on a regular basis. I think it's definitely getting the word out about those resources into the community. I think a lot of people still aren't aware of those fully. So being able to give them, here is a place that, they're non-judgmental, they're definitely helpful, that sometimes even with best intentions, the police it's intimidating sometimes to have, officers present during, say, someone's feeling suicidal or family dynamics are kind of problematic. So how do we give them the best resources to make them feel the most comfortable and the ones that are most trained and educated to be able to help them the most effectively? There is the Colorado Crisis Services, which is a 24/7 hotline that individuals in the community can call if they just feel like they maybe don't want to leave their house or they don't feel like they can go anywhere but just need to talk to someone. But there's a trained clinician or peer support that are able to essentially be there for the person in their most, vulnerable time. And then based on what is being said, are able to kind of triage and get them the support that they need, whatever that may be.
Right. And it sounds like from what you're saying that both these new resources built in Denver as well as the response unit are a terrific resource for police officers as well, as you say. Absolutely.
And from our team standpoint and the police, we try to message, especially since the Colorado Crisis Service line, being able to just call someone is, I feel like it's kind of taken for granted. It's such an easy thing to pick up a phone and do that. And it's just messaging. How do we get that people can call these people and essentially talk to a counselor on the phone and just kind of get that immediate need. So every time we make contact with someone, regardless, we're handing out cards to say 24/7, feel free to call them. And then giving officers resources on top of that to say, here's something, if we're not with you, that you can have access to call, have someone call.
Right. And the walk-in crisis centers and the stabilization units, are these free resources or is it a fee-based?
Yes, they definitely, they're part of the OBHS system. They definitely take insurance information that they can bill in the back end. I think the idea would be, though, that we don't want to create barriers for people that are trying to seek help. That someone that is in crisis, we want to make sure we're serving that person to the best of our ability. And that payment, I think, is one of those that we discuss in the back end on how does it get taken care of.
Right. Yeah, I guess that's what I was getting at. Is if someone could not afford it, is if the services would still be available to them. Yes.
Absolutely.
Okay. Terrific.
Absolutely.
Awesome. Okay. Well, you've already kind of touched on this, but I want to take a sec to look at some of the outcomes that you've been tracking from this program so far, because the results so far are pretty amazing. So I'm wondering if you could just talk a little bit about that and the outcomes that you are tracking.
So what we're tracking right now is essentially the amount of contacts, the follow-up services that are attached with those contacts, and then individuals in the community that are actually receiving services post-crisis intervention. So who are they connected with after immediately meeting with our team that hopefully provides that long-term stabilization, connection, opportunities outside of having ongoing legal or law enforcement presence. As you said before, we're at a very low percentage for individuals that are getting cited or arrested for on-calls where there's a behavioral health concern. So we're definitely tracking whether or not people are getting diverted to the most appropriate options versus jail.
We're also collecting data. We haven't analyzed it yet, but I made a reference to the known individuals in Denver that are frequent contacts for public safety, high-end utilizers effectively. Cross-referencing those that we've had contact with since April, comparing that list to the high-end utilizers and looking to see if we've had an impact. Our goal isn't necessarily to reduce patrol calls for service, but we think that's a likely outcome with affected contacts and getting people engaged in services. So we want to measure that over time by looking and seeing, since clinical contact, since the members of the Crisis Intervention Response Unit have contacted, both responding with officers as well as proactive follow-up, have we seen a dip, a reduction, or elimination of those individuals now utilizing 911 as a behavioral health navigation tool?
Got it. And will these outcomes be available publicly?
We promise not to keep them a secret. We just have
okay.
We will put banners from the buildings all over downtown to let people know what we're doing.
I should look for the billboard?
Well, you'll get the exclusive first rights to them.
Okay, that sounds great. Well, there's one other track that I want to take, and I'm wondering if, maybe Chris, but also Scott, if you want to jump in. We know that in mental health and particularly suicide prevention, that stigma can play a really significant role, kind of potentially getting in the way of help seeking. So I'm wondering if you have any thoughts on how innovative programs like this could offer a positive step towards addressing that stigma.
Yes, there unfortunately still is a huge stigma attached with mental illness. I think our program being able to, especially with the behavioral health concerns that we're going out on, meeting someone when they're in that acute crisis and being able to really partner with them or kind of relate to them, really be able to be there in that moment with them and kind of normalizing it, that what you're experiencing, the idea of anxiety, stress, frustration, anger, sadness, and really just saying, like, this is nothing different than any human on the face of the planet. What you're going through right now, like that emotional range is pretty normal. And we want to make sure that you're connected with the right people or the right places to be able to support that. And I think being on a call where someone's in that acute kind of mental health concern, I think they're really receptive to, I don't want to feel this way anymore. I want to, I want that life worth living. I want that something that is going to change my trajectory of how I feel right now. And being able to get them to those right places in that moment infinitely helps, especially from our program, which is a little bit different from the national programs, is we do follow-up work. We're not just leaving someone in crisis and saying, I hope you make it to this appointment. We're following up with them the next day or a week later to say, hey, like, do we need to meet for coffee? Can I meet you at your place? Are we meeting at the shelter to really be able to engage them? And I think having those discussions with people and letting them know that they're not alone kind of breaks down that idea that mental health isn't the 1960s One Flew Over the Cuckoo's Nest. It's really a community thing that we all deal with, that we all have to engage with. As a team, we really try to be proactive in really engaging people in that conversation and normalization of what they're going through.
That's terrific.
And then I also, just from the standpoint also is, this is the part from being on the social work side in the mental health field that I truly appreciate, is we also want to break down the stigma attached with the police. When we first started this, I don't think anybody realized what the two cultures coming together, what we were going to be able to, how we were going to be able to be utilized. And we quickly realized after being in a car with someone that what we're trying to seek is the betterment of the citizens of Denver, that we're trying to help people really those life worth living goals. The idea that recovery can and does happen, and police feel the same way. And the stigma over the past, 2-3 years has not been great attached with police. And I think once the police show that they are a co-responder, like they are part of this program, they are part of the solution, I think it breaks down the stigma attached with police as well, that we're all in this together trying to help people.
Absolutely. That's terrific. Okay, finally, as a kind of a follow-up, I'm wondering if you could kind of expand on what you just said a little bit more and tell me what you think maybe the program's greatest successes might be to date, and also if you see any areas of improvement, where would you like to go with that?
If I could start with the improvement, and I think it's just an evolution, is data collection. We have realized from the very beginning that the types of data that we're interested in that lends itself to, correlating positive outcomes or goals that we have is difficult with the standard police reports. Police reports were written for a criminal justice system and
right.
Goals and outcomes within that system, not necessarily a behavioral health model. So we're looking internally at we want to use a 21st century solution to engage 21st century issues, not kind of the 19th century solution to answer 21st century problems.
That makes a lot of sense.
And I think from the clinical side of success, it's I have a whole list of things that I feel like are successes. I think one is the partnership with the Denver Police Department. I think the sheer engagement from when it started was how do we respond to the 911 calls in a reactive manner, to kind of the evolution of now we're trying to be proactive about it. The police buy-in with, yes, we want to work on better solutions, better opportunities. We don't want to see the same people over and over again. We want to get them help and get them to the right places. So I think the partnership's been huge. The connection to community organizations is something that we really are trying to develop. How do we help the community? You mentioned stigma earlier. How do we help the community be educated on what mental illness is, and that there isn't this inherent danger every time the mental health word comes up? But how do we help those people? How do we get them connected? How do we make not 911 the immediate contact, but instead the right people to the right place to kind of triage it, to make sure that person, they might just be having a really bad moment instead of a one that needs police intervention. So our community members have really been on board with trying to kind of change the whole system of how we engage individuals and get them connected.
And this may be somewhat idealistic, but Mayor Hancock promotes the idea that global cities care for their people, which is echoed in Chief White's mission of operating an agency that involves crime reduction where everyone matters. And I think this partnership and the manner in which we respond demonstrates those values, that this isn't political speech making. It's action. It's looking at resources. How do we fund? How do we support? How do we sustain a meaningful program that literally touches people's lives in a positive way on a daily basis?
I'm all in for that. And I would really be interested in, perhaps in a little bit of time when you do have more of the outcomes and more things in place, we would love to have you back again. But before that, I'm wondering if either one of you has any final thoughts or something that you might want to bring up that we haven't covered.
I would like to add the level, not only the pride that we have established from good people doing good work with qualitative positive outcomes, the support that we've had, whether it be from the Office of Behavioral Health Strategies, from the Denver Police Administration, from Mental Health Center of Denver, from some other collaborative partners that we've begun engaging to look at enhanced suicide response and other avenues that weren't anticipated goals or outcomes when we first came together. The partnership, the reception, the integration within the department, this is truly a result of collaboration and goal-focused people coming together that has allowed us to get to where we are and will allow us to sustain, hopefully, continually successfully.
I'd like to add to that we would like to thank you not only for you taking the time to do this podcast, but also for all of the work that you've described, because it's very important to what we do. I mean, the mental health crisis response is kind of a cornerstone of what happens when someone is in a suicidal crisis. So I think everything that you've described today is extremely important and can provide good information for other communities and anyone who works within the mental health field. So I'd like to thank you very much for that.
Thank you again.
Yeah, and as I said, we'd love to have you back again in the future. So for right now, that's it for Rocky Mountain MIRECC Short Takes podcast, and we appreciate all our listeners. And if you want to learn more about the Denver's Crisis Intervention and Response Unit, we will provide some information and some links along with the podcast. And please do reach out to us with any comments or questions about this podcast or the work. Also, please take a moment to subscribe to our podcast and share with your other colleagues when you have a chance. And join us next time for more interviews on important work about suicide prevention.